Hello, my name is Stacey Charles, and this is my presentation on meningococcal meningitis. Meningitis is caused by inflammation of the leptomeninges, the lining of the brain and spinal cord. Meningitis can be caused by viruses, bacteria, or fungi. Neisseria meningitidis bacteria is a common cause of meningitis, particularly in adolescents and adults. Meningitis caused by Neisseria meningitidis is referred to as meningococcal meningitis. Here we can see a picture of the lining of the brain called the meninges. In meningitis, the lining becomes inflamed and looks like this. Globally, 50,000 deaths occur from meningococcal meningitis every year. The highest burden of the disease is in sub-Saharan Africa. Meningococcal meningitis is associated with a high fatality rate, up to 50% when untreated. Neisseria meningitidis has no animal reservoir and only affects humans. The bacteria colonizes the nasopharynx and respiratory tract. Neisseria meningitidis is transmitted through respiratory droplets. This can be transmitted through kissing, sneezing, coughing, or living in close quarters. Neisseria meningitidis has an incubation period that can range between 2 to 10 days, with an average of 4 days. Signs and symptoms can vary slightly depending on the age group affected. In infants and neonates, the fontanelles are not closed. This can result in bulging fontanelles. Other symptoms in the age group include consistent crying, poor feeding, inactivity, and excessive sleepiness. In this picture, we see additional symptoms of meningitis in infants. This includes arching of the back, cold hands and feet, shivering, and refusing to feed. Symptoms of meningitis in adults include a sudden high fever, stiff neck, severe headaches, confusion, and skin rash, which appears as a petechial rash. Here we can see a picture of symptoms of meningitis in adults. Again, the rash, the fever, stiff neck, and severe headache. Severe complications of meningococcal meningitis include hypovolemic shock, DIC, or disseminated intravascular coagulation, and the classical Waterhouse-Friderichsen syndrome, which is an infarction and hemorrhage of the bilateral adrenal glands. You can see a picture of the classical skin rash and the Waterhouse-Friderichsen syndrome, which is a hemorrhage of both adrenal glands. Initial diagnosis of meningococcal meningitis is made by a clinical examination. Lumbar puncture is then used to confirm the diagnosis. The CSF of patients with meningococcal meningitis is as follows. There is increased polymorphonuclear neutrophils, decreased glucose, increased protein, and a positive gram stain for the bacteria. Diagnosis of meningococcal meningitis can also be confirmed using PCR or polymerase chain reaction and serum latex agglutination test. Patients at a high risk of contracting meningococcal meningitis include patients without spleen, such as sickle cell patients, immunocompromised patients, and persons living in crowded environments, such as in the dormitories of college campuses and in the military. These groups should be offered vaccinations. Meningococcal meningitis can be prevented using vaccines. There are 3 types of vaccines available today. There is a polysaccharide vaccine, which is effective against serotypes A, C, Y, and W. There's also the conjugate vaccine, which is also effective against serotypes A, C, Y, and W. And finally, there's a protein-based vaccine, which is effective against serotype B only. Meningococcal meningitis can also be prevented using chemoprophylaxis. People in close contact with patients with meningococcal meningitis are given oral rifampin or intramuscular ceftriaxone. Persons who require prophylaxis include, but are not limited to, household members, intimate contacts, and persons directly exposed to oral secretions, such as during kissing or intubation. The management of meningococcal meningitis is via antibiotic treatment. This includes intravascular ciprofloxacin, which is the treatment of choice, also ceftriaxone and vancomycin. Steroids, such as dexamethasone, can also be added in the treatment regimen. Here we see an algorithm for the management of meningococcal meningitis. So a patient comes in with a suspicion of bacterial meningitis from clinical symptoms. If the patient is immunocompromised, has a history of CNS disease, new onset seizures, focal deficits, papilledema, altered sensorium, and there's a delay in performing the lumbar puncture, a blood culture is ordered immediately. If positive, the patient is given dexamethasone and antibiotics. A CT scan of the head is then performed to rule out any masses. If there are no intracerebral masses, a lumbar puncture is performed. If this LP is consistent with pyogenic meningitis and the Gram stain is positive, the patient is continued on the same therapy. However, if the patient is not positive for any of these on the top, a blood culture and a lumbar puncture is then performed. If positive, the patient is started on dexamethasone and antibiotics. If the CSF is consistent with meningococcal meningitis, regardless of whether the CSF stains positive for Gram stain or not, the treatment is continued. However, if the CSF is not consistent with pyogenic meningitis, an alternate diagnosis is considered. This brings me to the end of my presentation. Thank you.